it's a very cryptic title, of course, but you will find out why it's called broken pipe. It's called broken pipe because that's when her symptoms started, when her pipe in the apartment broke. What happened was that it's an older woman, and she had a broken pipe in her house, and everything was underwater, and she was really in despair. And all of a sudden, she became very dyspneic. She developed chest pain, and she had to call the ambulance, and she had to go to the hospital, and she was brought to the hospital immediately to the emergency department, where we found ST elevations and ST T-wave abnormalities, and this echocardiogram. Let me see if I can go. Okay, this was 2006. Okay, and this echocardiogram. Okay, we can see the parasternal long axis view. Obviously, the first thought we had is that the patient has some form of left ventricular dysfunction. The aortic valve is okay. Look at the mitral valve. Take a look at how the opening of the anterior leaflet is. It does not even come close to the septum. This is usually a sign of reduced left ventricular function. Okay, this is the aortic valve, mitral regurgitation, just a bit of regurgitation, not very much. Okay. Again, the M mode, short axis view, not so bad actually here at this level at least, but there is pericardial effusion right down here. Okay. I just see that Guillermo and Heng already have the right diagnosis. I'm not going to tell the others what the right diagnosis is, but once you see this image here, let me see if I can get the moving image. Okay, this is a very abnormal echo. What do we see here? We see an aneurysm of the entire apex. There's practically no contractility here in the apex. And inside the left ventricle, there's a huge, huge mass. Now, what do you think this is? You see that there is echolucent areas within this mass. Okay. Just another view, apical long axis view. Now the basal segments are doing fine here actually. It's just that the apex is completely akinetic. Okay. You don't see these echoes very often. It's a fairly obvious finding here. Right ventricle function is completely normal. Just give you more impressions of this. Again, the pericardial effusion here, enlarged left atrium. She needed diuretics. She was in pulmonary edema. There's not very much mitral regurgitation. Now you will ask why, even though the ventricle is so large. The reason is simple, because the basal parts of the left ventricle are not very dilated. That's why there is not much of annular dilatation, and therefore not very much mitral regurgitation. There is tricuspid regurgitation, and this is the pulmonary pressure. You can see that we have almost 3.7 meters. So again, a pulmonary systolic pressure in the range of maybe 64 millimeters mercury. So very high pulmonary pressure. Okay, this is the apical or the parasternal long axis view of the right ventricle displaying tricuspid regurgitation. The inferior vena cava is also dilated. There is not much change in the diameter during inspiration. Here is a very large inferior vena cava. Normally it should be somewhere in the range of maybe 17 millimeters. Here it's 20. And there's just a bit of pleural effusion as well. Now to the question. Which vessel is occluded? Obviously, we had to perform coronary angiography in this patient. We had chest pain, we had dyspnea, we had ECG abnormalities. So the next step is coronary angiography, and she was put on the table immediately. can see there's almost a close competition between LAD and none, and some put left main. Okay, can we close the poll? Okay, so those are the results here. Okay, LAD and none, and some think it's left main. I mean, to be honest, without performing the angiography, we could not tell. But those who said none were correct, and I will show you the angiogram. I think I have it here with me. Let me see if I do have it. Oh no, I don't think I have it with me. But in any case, the patient had normal coronary angiography, and the reason is because she does not have coronary artery disease, and the cause of left ventricular dysfunction was certainly not coronary artery disease, but a Takotsubo syndrome. What is Takotsubo? Some of you will already know this pathology. It's a pathology which is also called stress-induced cardiomyopathy. It's an entity which has only been discovered, I would say, in the last maybe 5 to 7 years, and it is a pathology where very strong emotional stress, such as in this case a broken pipe, causes extreme amounts of catecholamines to be secreted into the blood, which cause left ventricular function to deteriorate. It is a pathology which is more common in women. Some suspect that there is a microvascular spasm, at least as a component to this disease. Sometimes you might even see right ventricular involvement, and it is a reversible process. Typically, it causes a cardiomyopathy where we have the criteria that I showed you in this patient, where the apex is very dilated, while the basal parts are not as involved, and the ventricle has the shape of a vessel that the Japanese use to catch octopus, which is called Takotsubo. This is where the name comes from. And it's a pathology that we are now more and more frequently aware of, and where we also know that some patients might not even have such severe and extreme forms, but sometimes only discrete forms where only parts of the septum or parts of maybe even the lateral wall are affected. So this is a case of Takotsubo. By the way, she also has a very small patent foramina ovale. There's a small little shunt here between the left atrium and the right atrium. How did the patient improve? Well, she did fine, and she got better and better. This is the next echo we did, and you can see that her left ventricular function is now better already. The thrombotic masses are starting to deteriorate. The wall motion abnormality is still present here in the apex. So she's improving only after a few days already. And let me go back to the follow-up now, approximately 1 year later. Let me see where that is. Okay. This is 1 year later. Her pipe was fixed, and so is her heart. You see, she now has completely normal left ventricular function. And this is the 4-chamber view. You would not think that the patient ever had such a pathology. So in contrast to myocardial infarction, there is no scarring, and it's a completely reversible process, which is actually also part of the definition of Takotsubo syndrome. One can even go so far as to perform a speckle tracking or strain rate analysis. This is what we did here. And here is the speckle tracking bullseye display, where we have an even supranormal global longitudinal peak systolic strain of -22. The normal value is somewhere in the range of 17, and no regional abnormalities in the global strain. I just got a question: why is regional wall motion and not the whole left ventricle? Yes, that's a good question. Well, as a matter of fact, we do not know why the apex is more strongly involved than the other parts of the left ventricle. Maybe it is more susceptible to the high doses of catecholamines. I have, however, seen patients where not the apex, but other parts of the ventricle were affected. So there seems to be some degree of variation. It might also be due to the fact that the patients might very often also have high blood pressures, and this high blood pressure tends to kind of bulge out the left ventricle at the apex. This is just a suspicion that I might have, but to tell you the truth, I do not have the exact answer why this is so. It's just that the typical feature is that of apical ballooning or the shape of a takotsubo. Did the patient get anticoagulant therapy? Yes, we had to give her. She was put on, obviously, on a low molecular heparin simply because of this huge thrombus, and something that is frequently seen in patients with takotsubo, but it does not have to be present in takotsubo. So sometimes you see it, sometimes you don't.